It's my pleasure to give a presentation on transcutaneous carbon dioxide monitoring and non-invasive ventilation. So you have 0.5 seconds to have a quick glance at my conflicts of interest, lecture fees and open research grants. Well, first of all, I'd like to point out that transcutaneous measurements and all the other measurements for carbon dioxide are actually not competitive. They are rather supporting each other. And there's no doubt that in the ICU setting, for example, we need to have the most exact values, and therefore the sense and value of arterial blood gas measurements are undisputed. However, if we look at transcutaneous CO2 monitoring, the clear advantage is that it is non-invasive and it is continuously monitoring CO2, and therefore transcutaneous CO2 monitoring specifically qualifies for endoscopic procedures if sedation is being applied, and in patients with chronic respiratory failure, and particularly those with non-invasive ventilation and sleep studies. And I will just give you an example. This is out of a publication by a case series of 34-year-old patient with congenital central hypoventilation syndrome. And you can see that this is during a study. We have measured blood gases 4 times. And if we had just measured here at the beginning of the night and at the end of the night, everybody would have probably concluded that everything's fine. But transcutaneous monitoring clearly displays that something went wrong during the whole night, even though the patient had been established on non-invasive ventilation for a couple of years. So PCO2 values went up from 40 to 80 millimeters of mercury, indicating that nothing is correct in that patient. And this is another interesting case. And this is an ALS patient, and we have measured this patient during spontaneous breathing as well as during subsequent non-invasive ventilation. At the beginning of the night, the patient was already severely hypercapnic, but hypercapnia increased overnight, and suddenly here, at this occasion here, the medical students working in this lab decided to increase the amount of oxygen. And of course, according to the physiology, there was a huge increase in transcutaneously measured CO2. So the students had removed the oxygen supply. And it's actually funny to see, as if they hadn't believed what was happening, they tried this another time, so during the second part of the night, and they had to display that there's no negotiation with the physiology, and of course only non-invasive ventilation is capable of getting down the CO2 in this scenario here. Of course, without having measured CO2 values transcutaneously or at least continuously, this was probably not become available here. So, of course, we do have another technique measuring CO2 in a continuous way, and this is end-tidal CO2 monitoring. Now, there's a clear disadvantage for end-tidal CO2, and that is depending on the ventilation perfusion mismatching. And this is just one example of numerous of studies done so far in the literature comparing both transcutaneous and the gold standard of arterial and end-tidal with the gold standard of arterial blood gas measurements in patients undergoing prolonged weaning. And this is the so-called Bland-Altman analysis. And if you are not familiar with this, just briefly, just to show, this is the mean, the red line is the mean difference, the overall difference between the two methods, showing that in case of transcutaneous CO2 monitoring, this measurement perfectly fits the gold standard of arterial measurements. But if you go onto the right-hand side, you can see that there's a -6 difference between end-tidal and arterial blood gas measurements. So end-tidal clearly underestimates the amount of the gold standard, which is PaCO2. And the other one is the blue line, showing the variation. And you have already mentioned that this is the 95% limits of agreement. And the more narrow this area is, the better the measurements fit with the gold standard, and you can clearly see an advantage for transcutaneous CO2 monitoring. Well, this was also shown by the paper from our group, from Jan Storer. He's just entering the room and looking for a seat. Here we have again shown that during the initiation of non-invasive ventilation, that transcutaneous monitoring can be quite helpful. Of course, that time, 10 years ago already, there was the problem with the drift correction, and you see that if we go for drift correction afterwards, both the mean difference and also the 95% limits of agreements appear to be much better. And this is just another case example of how it works overnight. You can see the body position. Yellow is the supine position and blue is the lateral position. And at the beginning, for the first 90 minutes, for example, we had been quite unsuccessful in getting established the patient on non-invasive ventilation. And when the patient was changed to the from the nasal to the full face mask, we were quite successful in getting down the PCO2, but eventually the patient fell asleep, so there was in the end upper airway obstruction and the CO2 was about to increase, and then we forced the patient to change body position from supine to lateral, and then we had been successful eventually with getting the patient established on non-invasive ventilation. Again, you can see the red points reflecting arterial blood gas analysis, the green line, the drift-corrected CO2 values transcutaneously measured, and the blue one, the original measurements. So we did also a trial in obesity hypoventilation, and I do not want to go into much details, just to show that transcutaneous monitoring obviously has the capacity to differentiate between different modes of ventilation, as CO2 values were reportedly lower when patients were receiving target volume ventilation in this setting compared to the conventional approach, which was pure pressure support, even though there were no other differences in the outcomes, namely the quality of life measurement tools, the SRI, and the sleep quality in terms of the group differences. And this is another example how it might work, the mean transcutaneously measured CO2 during sleep, when obese patients received pressure support ventilation compared to pressure support with the addition of target volume ventilation. And there was a clear advantage for target volume ventilation in this setting, but at the cost of a reduced polysomnographically assessed sleep quality. And I do not want to discuss the outcomes, but again, just to show that transcutaneous measurements of CO2 are capable of discriminating between the two modes. Well, and again, this is the most recent and probably the best trial on target volume settings in obesity hypoventilation syndrome, and the authors nicely decided to use transcutaneous monitoring as a primary outcome, and they showed that if pressure support ventilation is maximally optimized, then in comparison to target volume ventilation, there's no significant difference between the two application modes, and therefore there had also been comparable effects on daytime PCO2, weight loss, quality of life, and subjectively reported sleep quality. And there's another issue of interest, and that is the question targeting the value of target volume ventilation in patients with COPD. And for that purpose, we performed this trial and included patients already established on high-intensity NIV, and these patients had been switched afterwards to target volume ventilation. And for the high pressures, we used 26 centimeters of water, and for target volume ventilation, the inspirator-positive airway pressure was allowed to go down and to go up in accordance to the predefined target volume, with an average minimal IPEP about 21 and an average maximum IPEP around 35 millimeters of mercury. And overall, you can see there was no difference, so no clear advantage for target volume ventilation in patients already successfully established on high-intensity NIV. But a closer glance at the graph here on the right-hand side clearly displays that on an individual view, that there might be some significant deteriorations or further improvements once patients get switched from one to the complementary mode. So this needs to be kept in mind when treating individual patients, and underlines the importance of continuous monitoring overnight. And Prashant, you have already mentioned this paper. Just to repeat the main results, again, we have investigated comparably 3 different devices. And first of all, the mean of the difference was around 0, actually, and quite successful. So here displaying the gold standard of arterial blood gas analysis, even though we have to agree that there are some limits of agreement. So in some cases, values might range between the gold standard, and we have eventually concluded that nevertheless this is within a clinically acceptable range. Well, we have also published our revised German guidelines very recently, and have also provided an international translation in the full length within 2 different parts in the journal Respiration. And I do not want to go into detail and want to show you all the algorithms, just to show that we have also included now in our guidelines transcutaneous monitoring to serve as an indicator for non-invasive ventilation. And this is particularly true for chronic stable hypercapnic COPD, but also for an increase in nocturnally measured CO2 in patients with obesity, hyperventilation syndrome, and even not shown, even though it's not shown, this is also true for neuromuscular patients and those with restrictive thoracic disorders. And at the end, I'd just like also to push the Dutch projects, because the Dutch people are very keen on also looking at the outpatient possibilities in both controlling and implementing non-invasive ventilation in the home environment. And again, I do not want to show the details, but just to show that non-invasive monitoring is used in the home environment to decide if ventilation is set sufficiently or not. And the last study I'm going to show is a recent trial again from our side, looking at the feasibility of outpatient control of long-term non-invasive ventilation in the outpatient setting. One interesting result out of this, by the way, does not target the topic here, but is actually that about only 1/3 of the patients with COPD do receive NIV because of stable chronic respiratory failure, while the rest of the patients, about 2/3, do receive non-invasive ventilation following an acute event in the hospital. However, in regard to hospitalization, we have created an algorithm with major and minor criteria for establishing the need for hospitalization, and just to show that also if there were any doubts in the patient's ventilation quality, we have underwent daytime ventilation using transcutaneous CO2 monitoring in order to decide if ventilation is sufficiently set or if further controls are needed in the hospital environment. So this was my talk from my side. Thank you very much for your attention.